Hey, everybody. Welcome back to the You Are Not Broken podcast. We are going to have a fiery, feisty, fantastic conversation today because I met at the Ishwish conference in February 2026, Dr. Linda Bosserman, MD, PhD. And the reason I was attracted to you is I don't even remember what they were presenting, but you stood up at the end and you were basically schooling them, I think, on the difference between progesterone and progestin, if it was not the difference between oral conjugated equine estrogens versus
Yes.
estradiol. It was something like that, which if you know, you know. And if you don't know, you don't know. But I was like, okay, that's a sign that a person knows something about hormones. And I was like, who is she? I must meet her. And now we've written 2 editorials already together. Like,
Yes.
watch out, world. Welcome to the podcast.
Thank you so much. It's such a pleasure to get to know you. I've learned so much from your podcast, and I'm happy to share and really work to get information out so people can make better choices and have better health. This is just
I love
so
it.
important to people, to
So you
women.
are a practicing oncologist
Yes, I
in
am
Los
a
Angeles.
board certified medical oncologist, full professor at City of Hope National Cancer Center.
Thank you
I
for doing
don't
that.
speak for City of Hope in my podcast or private work, but I teach and lecture, and I have a clinic 2 days a week only for patients who have had cancer and sexual or menopause or andropause side effects. Actually, I'm only seeing women now because I'm booked through August. There's not enough practitioners with knowledge. And then I'm writing and publishing, and after 40 years really as a breast medical oncologist and value-based specialist, instead of drinking during COVID, I went back and got a PhD in sex therapy because it seemed like a good thing to do. Actually, my partner's a therapist and a couples therapist, and he wanted to do it.
You're
So we
like,
did it
I can do
together.
this as good as you can.
Yeah. Well, I mean, more that think we want to put the bio in biopsychosocial. You can do all the cognitive behavioral therapy you want, but if your vagina's raw, you don't want sex. I mean,
Dude,
let's talk about
I
it,
got
you
into it.
know?
Like, I'm like, I'm the bio person who's like, I
Yeah.
can make your vagina and pelvis perfect. I can give you erections. I can do all those things. But if you think sex is dirty, it's too much work, you don't like your partner, like, your perfect pelvis isn't going to have great sex.
Exactly, exactly. I have a woman who had never had great sex, has an idiot for a husband, went and had all her hormones optimized and testosterone and said, "Oh, that's an orgasm. That's why people have sex. Where are all those toys you taught me about? Because my husband's still an idiot." So, you know, it's like you do have to go where the patients are.
Yep. Yep. You gotta move, you gotta pull all levers, not
Hmm.
usually at the same time, because it can be a bumpy ride. But all
Yes.
levers must be pulled, and it's important to have people understand. I think and correct me if I'm wrong, but we're seeing this in the sex therapy world now, but we saw it in the past. Like, or erections were just all in your head. Women's
Yes.
desire is just all in their head. We're kind of seeing this like anti-medicine belief system from the
Hmm.
therapy world. Not all therapists,
Yeah.
but like, it's not all talk therapy. Like, we
Right.
need hormones to
Right.
have good sex.
And I think, one of my greatest failures many, many years ago in practice was a guy with cancer everywhere in his body. And he said he wanted to have sex again before he died. And I optimized his testosterone. He came back so happy. And his wife sat there and said, "What did you do? I've always hated sex. And
Oh,
here I'm thinking I'm doing
yeah.
a good job and I have failed."
Yeah.
Right.
No, you
So
gotta ask you
again,
gotta ask who's
yeah,
treating the partner. Right.
exactly.
Yeah.
And so many women do not know that, when they start menopause, they often already have atrophy. They're often losing their testosterone. So I say by 40 or 50, lots of women say, "I don't know why men want sex. I'd rather read a book." You give them optimized hormones, testosterone, estradiol, and they're like, "Get over here. Let's have fun."
Yep.
It changes everything about the
It changes
relationship, the
everything.
intimacy. Yeah.
Let's talk about late breaking news. It won't be late breaking
Yeah.
by the time the podcast comes out, but late breaking news literally this morning, the FDA put out a press release saying we want to help men more with testosterone. So we're looking for companies who want to come forward and try to get testosterone FDA approved for low libido in men.
Hmm. Well, I mean, 1 in 5 men lose their testosterone from 40 on. So it is an issue. It leads to metabolic dysfunction, diabetes, but they have all the
Depression,
products they can use now. It's just not
dementia.
covered by insurance. And I've seen insurance clamping down on not covering it, except for "I was born that way," which is absurd.
Yeah, and to clarify
So
that for people, so currently the FDA-approved indication for testosterone for men is primary hypogonadism, meaning I was born without the ability to make enough testosterone. So about 2/3 of men in the United States of America do take testosterone off-label. So what
mhm,
you're talking about is, especially in the state of California, insurance companies give me a break too. A vial of injectable testosterone is $10, right?
yeah,
Like, is this where
yeah,
is this where the cost savings are coming from? But they're clamping down on the men, saying you actually don't have primary hypogonadism. So even men, I say even men because women have way worse. Everybody's yelling at their speaker right now at us because they're like, women have nothing. And I want
yes,
to acknowledge that. But a lot of
yes,
men take it off label or for a reason that's not actually indicated. But I would
mhm,
argue the FDA should get it approved for secondary hypogonadism,
yeah,
not low libido, because most private insurances have a sexual health rider on them. And people are like, it doesn't really matter for men because Viagra's cheap, cash, right? And so is testosterone. But I would argue it's the wrong indication if you wanted to expand access. Secondary hypogonadism is the right indication. And where the hell is the female testosterone?
right. And if we get it based on the last studies that went to the FDA at 10 milligrams per day, which, female dose testosterone, I consider 2.5 to 10 milligrams a day. I have a woman on 60, I have them on 20, I have them on 1. But in general, you start low, you go slow, you see how that woman does. She gets to decide. I tell everybody the only important person in the room on a consult is the woman. How does she do with this drug? I was on a website with very conservative doctors saying, we have to control testosterone in women. They might overuse it. I'm like, where? Women don't want more than what
Yep.
works for them as a balance.
Yep.
And, women don't generally want a libido off the ceiling
That's
where they
out of
can't go to
control.
work.
Out of control libido is not
Right.
unpleasant for the
No,
majority of
it's
people who have it. They don't want it.
yes.
They
And they
want just
cut
enough.
back. Yes.
Just
And then
enough.
it's not just libido. It's I got myself back. Or a woman said last week, the world is now in color again. Where's
Yeah,
the
I love that
patient
one.
reported outcome for that? I have
Yeah, I love that.
myself
They're not
back.
measuring that. The
We're
first
not
time a woman
measuring.
said to me, she was even more specific. She's like, "You know that scene in The Wizard of Oz when
Mm,
Dorothy goes from black and white to Technicolor? That's
mhm.
my brain on testosterone."
I love it.
Isn't
I
that
I had
great?
a woman who biologically had a larger clitoris and labia in the past, and it came back, and the gynecologist was horrified, told her she should stop. She goes, "This is my normal body." And then she said to me, "I don't care if I die 5 years sooner. I am alive and well, and I want every day of quality for the life I have."
I
And
love
yet
it.
there's no evidence it does anything but make you live longer and better.
Well, here's my question.
Mhm.
Because I'm just going to harp on the FDA for a hot second for libido.
Yes.
So the Intrinsa patch went up, 300 microgram patch a day, 4-year safety data went up in 2004, did not get FDA approved. The indication attempted was for low libido, did not get FDA approved because the fear of hormones in 2004, because the Women's Health Initiative media took that in 2002, right?
Right.
So we have 4 years of safety data that did not get FDA approved for low
Yes.
libido. And now the FDA wants to jump to, are they going to have 4 years of safety data? Are they going to make them go through the same hoops?
They had to
I mean, at what
reevaluate
point do
that
we have a
study.
gender discrimination issue here?
Oh, it's unquestionable gender discrimination in funding, in research, in priorities for women's health. And women are going to have to get together and lobby for this. But we could lobby first to re review that data. And when you think about it, the lie that happened was the idea that was completely debunked by the Women's Health Study. Even horse urine estrogen, conjugated equine estrogen over 20 years, lowers breast cancer risk 23%. So the people that worry that testosterone has some conversion to estrogen and therefore it must cause breast cancer do not know the data either from the Women's Health Study or Olive Glazer's study at high doses showing it lowers breast cancer
You
risk
read my mind.
40 to 50%. So we have to go back. I think they could reevaluate the data they have if that company was willing.
As that was Procter and Gamble.
Hmm.
I'm pretty sure. So let's talk about Rebecca Glazer's data. This
Yes.
is a large amount of women. This is testosterone pellets versus a national SEER database standard. So your standard rate of
Yes.
breast cancer. So this was because the critics will say
Yeah.
it wasn't testosterone versus placebo in a group of women. It was
Right.
testosterone versus this baseline SEER database, expected amount of cancer in a population.
Yes, and the
So
Million Women study, you could look at any large database against it, and it's significantly less.
that's like 30 to 40% less breast cancer.
Yeah,
Why
so it's
why are we not
DCIS
screaming
was
this from the
yeah,
rafters? Why do we not have
yeah.
NIH grants trying to replicate this to check it? Like, if people are like, they're poo-pooing it, I'm like, check it then.
Right. Well, I have found in my lecturing now in the academic spheres and different, really getting things published is that people do not know that estradiol does not cause breast cancer. The only association with increased breast cancer risk is synthetic high dose progestins, like in that one arm of the women's health study, like in other studies. And it's 1 in 1,000, like being obese or drinking alcohol every day. It's not zero, but there's less with estradiol long term in studies now with women with BRCA1/2, women who get pregnant and have thousands of micrograms of estradiol in their blood for months don't have an increased risk. So we're going to have to get over this confirmation bias that estrogen causes breast cancer. And oncologists, I think, are the key right now because they have such a bias that because we use drugs that we think block the estrogen receptor, that clearly have evidence of improved survival and disease control in higher risk women, lower risk, there's very little benefit, but individually, because they think it's an on off mechanism. The estrogen receptor is not on off, it does 50 things and it's often anti-proliferative. There's 3 different parts of the receptor. So it's not estrogen increases, blockers decrease. That's our problem we have to address with science. And I've been
Yep.
working on a paper showing all these mechanisms.
I think that's key because people think they call them hormone blockers or estrogen blockers. So you think it works by blocking the estrogen receptor,
Right.
but I mean, it's look at tamoxifen. How many
Yeah.
different ways does tamoxifen work? Right, it works in
Yes.
tons of different ways. And once some person was telling me very recently that they think there might be like an anti-mast cell, like an
Hmm.
anti-inflammatory nature to, I think, at least the aromatase inhibitors. Of like these
Mm-hmm.
things are working in ways other than preventing the big bad estradiol from like putting a stake in the breast and causing cancer.
Right. Because do we ever measure estradiol? No. And tamoxifen, the average estradiol level runs 95. It does not run low. In AIs, it will be very low or ovarian suppression. But we don't know that that has any association with the actual benefit to breast cancer. Breast cells have the most aromatase. Maybe it's helping up the breast cell. That doesn't mean you can't give estrogen back, progesterone back, certainly testosterone, because if you believe it converts, which it really doesn't have a lot of high conversion
Yep.
by blood test,
Yep.
it will not on aromatase inhibitor. So the minimum for women on AIs to me is vaginal estrogen for healing and then strong consideration of testosterone, not really always for libido, but for brain fog, memory loss, energy, all the depression, anxiety, the tortures of aromatase inhibitors.
Let's talk about that a little bit because I know you and I know, but for the general population, it'll piss me off to no end for people to say it's testosterone's only indicated for libido.
Oh,
And then
yeah.
again, going back to the FDA, like FDA, really, your second indication for men is going to be effing sex drive? Like, there's so many different. Like, how about prevention of diabetes, which it
Hmm.
does, right?
Yes.
Like,
Yes.
putting it on libido, number one, decreases how complex libido is. Libido is not
Yes.
an on-off switch directly correlated to testosterone number. It just isn't,
Yep.
right? But when people say, "Well, you can't have this because it's only for libido," or "Its only indication is for libido," I'm like, that just tells me you don't know how the brain works,
Right.
right? Like
It's
there
one of the
isn't a little
largest.
spot in the brain that testosterone just goes to that one spot. Like it lights up the brain,
Mhm. It's so
and by the
important
way,
for
libido's
so
a
many of
mode.
those neurocells. That and estradiol, they help neurodegeneration, neurofunction. And you just ask a woman who has word finding and brain fog, it can be remarkable to go on testosterone
Yeah,
and
but
they get
Linda,
their
then
life
we would
back.
have to listen to women, and then we would have to believe them.
Yes, yes. Well, that is the problem. And, I really want to call out to all our colleagues who are dying in factory clinics. They're working 12 hours a
Ooh,
day.
I'm stealing that.
They're dictating hours and they just have to stay in their lane, which is why I say we have breast cancer blinders. This is what we do for breast cancer. We don't care if your risk is super high or super low. we have to customize.
Yep.
But they don't have time, right?
Well, there's
So,
no time for curiosity when you're being worked to death.
yes,
Ask how I know,
yes,
right? Like,
because we've
we
been
all
there.
know this. Curiosity goes out the door. Listening to somebody going off label. The other thing
Yes.
with the factory clinics, because let's just pick on them since we're here, is so many people are afraid of losing their job because of
Yes.
prescribing off label.
Hmm.
And it's really weird because 60% of the medications in this country are prescribed off label.
Hmm.
But especially for women and breast cancer, people they're worried about litigation, they're worried about losing their job, and I don't want to downplay that. That fear is real. But you're like, 60% of the medications in this country are prescribed off label. Why are you so rigid on this one issue?
Right. And I think when I talk to my colleagues, it's because they don't know the data. They're like, okay, tell me this. I don't know this. When I talk to our endocrine department, an academic department with 40 people, including some outsiders who were visiting you, they're like, we don't know this data synthesized like you have it. Tell me every study in women of estradiol, CEE, progestin, progesterone, synthesizing graphs and charts that I've worked on for 6 years. And we don't know the data in women and we've not parsed it. And that's why I think the publication that Dr. Dazan and I did in JCO 2 weeks ago was so important, because when I sent the editorial in, they said, well, you're so far ahead, show us the science. So I wrote a month of science. They said, that's great, cut it in half to fit. So half of it's on the floor and, the charts are there. What did habit study really show in women with breast cancer? And, somebody stood up at ASCO 2 years ago and I was embarrassed for them because they said, we can't give hormone therapy to women with hormone positive breast cancer because of the habit study, which was a 2.5-year study they followed up of synthetic high dose progestin in 72% of the patients. At the same time, the Stockholm study used the same conjugated estrogen with minimal progesterone, none or low dose, and had no breast cancer risk. People
And that's
don't know
11
the
years,
drugs.
published up to 11 years follow up on
Yeah,
Stockholm.
yes, exactly.
Because I
And
just
when you do a
saw,
meta-analysis, there's no increased risk. And that's where
yep.
the Poggio meta-analysis is a
That's a
tragedy of
that's a piece
publication.
of bullshit and
Yes.
should be blamed on the editors and the reviewers for
Yes.
accepting it, and the reason is, and then let's break it down for the
Yes.
people who need to catch up. They threw in a paper, with tibolone, and tibolone is a synthetic, which you can't even if you wanted to give a patient tibolone, which you
Yeah.
shouldn't because you don't know anything, but even if you you can't get it in America. It's not even available in America.
The FDA declined it. It was way too toxic with
So they
clots
threw
and it caused
that
breast cancer.
paper
Yeah.
into the meta-analysis and then said you can't have hormones after breast cancer.
Yeah, and there are like 3,400 people in that study. It was such a big study and such bad outcomes. The RFDA said, don't ever think of using it. And the two trials that actually had menopausal hormone therapy at that time are the only relevant randomized controlled trials. And they were much smaller, 300 in the 300 range of women who entered. And then they were stopped early for misunderstandings. Remember, the original women's health study of conjugated estrogen alone or conjugated estrogen with synthetic toxic medroxyprogesterone, the paper in 2002 actually said the risk of breast cancer almost met statistical significance, meaning it
Phenomenal.
was not significant.
It was not significant, my friends, but the media took it.
Mhm. Yes.
Let's talk about
Yes.
the media for one hot second.
Oh, yeah.
So there was just another journal article published in the Menopause Journal in February. And I
Yes.
did an immediate Instagram post because I said, watch this paper. It's going to be used against you.
Mhm.
Watch this paper. It's going to be used against you. It was a database study looking at air quotes hormones. And
Mhm.
nowhere in the study they actually say what hormones meant. We don't know dose. We don't know route. We don't know type. We don't know anything. And the relative risk of like stroke is like greater than cigarettes by like
Yes.
massive
8
quantities, like
times more.
8 times. So like the relative risk itself is a warning of like this data seems a little fishy, right?
Yes.
And so I said, well, watch it. This is going to be used against you. So that was February. And then what happened in March was Medscape, which is a big online kind of news of the medicine focusing on doctors, basically says headlines: hormone therapy increases risk of cancer and strokes.
Yeah. In women over 65 when
in women over
started.
65.
Yeah.
And I'm
Yeah.
like, and so then I'm like, there it is. And so
Yep.
you and I wrote a letter to the Menopause Journal, basically
Mhm.
saying, please try to do better.
Yes.
And then I actually did a video with Dr. Rubin for Medscape
Oh, you
saying,
did?
saying headline, like, do not believe clickbait headlines. And furthermore, Medscape, do better.
Yeah.
Because
Yeah.
you're supposed to be known for like good medical interpretation.
Yes. Well, they
And
have
it
a
seems to have
million
died
MD
down.
subscribers. They have a
What,
million MD subscribers.
a
It's a
million? Dude, there's
travesty.
a million physicians in America. That's as many physicians as there is in America.
Yeah.
It's a
So
big
it's
platform. Do
yeah.
better.
We could really look if as I studied for my dissertation and read thousands of articles, I was shocked at how sloppy our medical literature is, and everybody needs to be on alert. First of all, things get spun by the PR department to sell a drug. That's just reality. But second of all, it's not uncommon to say progesterone causes something when the drug was a synthetic progestin
Over
because
and over and
over and
over again.
over. And then estrogen mixes oral estradiol or transdermal and conjugated. And the guidelines to this day say that oral estrogens increase the risk of clotting. Therefore, you should all have transdermal. And that is not evidence based. Conjugated equine estrogen, yes, increases the risk of clotting 17 per 10,000 women in year one.
Less
You
than
add,
pregnancy, less than birth
yes,
control.
yes, but more than the population baseline of like 6 to 12 per 10,000. So remember, we all have a risk of something in the population. That doesn't mean giving something causes it. If you look at transdermal, it has the exact same risk as oral estradiol. And oral estradiol has some of the longest randomized controlled trials in DOPS, where they gave 2 milligrams of oral estradiol for 10 years in a row and no increased breast cancer risk, no increased clot risk, 52% cardiovascular disease risk and mortality. So,
Reduction. 52%
yes,
reduction. Yeah.
reduction.
Mhm.
Yes. So,
Thank you for bringing up the DOPS trial. We don't talk
look at
about
the
that enough.
science. It's so important.
The other very interesting thing is the Iron Curtain of 2002.
Mhm.
People ignore any published data prior to the WHI as if it doesn't exist.
Yeah.
And I'm like, some of the best hormone data was done in the 90s.
Yes.
There's
Yes.
great hormone paper data from the 90s. But people, I went on this rant like a week ago because people are like, there's no data. And I'm like,
Oh my
you
God.
not knowing the data is
Mhm.
different than there's no data. Don't
Yes.
confuse the two.
Yeah, Dr. Hodis has become one of my heroes. I want to go have lunch with
Oh,
him
I love
right here
him.
in my backyard at USC, chief of cardiology, 35, 40 years of careful research in women's hormone management showing oral estradiol is the best at reducing plaque in the arteries by the carotid intimal medial thickness, in stopping early bone loss, and improving overall survival 3 to 5 years and reducing cardiovascular death rate. Our number one cause of death in all women, breast cancer or not, is cardiovascular.
Heart disease. Yeah.
Yeah.
I know. It's great.
And there's not
So
one
I was
study with statin showing improved survival in women as a
say
primary therapy. There's no study of statins showing improved survival in any study in women as primary therapy.
right.
Only
Primary therapy, meaning
estradiol.
prior to having a heart attack.
Mhm.
There is data that says it does decrease risk of cardiovascular event,
Events.
but we don't have any survival data.
Right. Except with estradiol.
I was literally on a stage last night in Seattle. And it was like a longevity style
Yes.
forum, right? And
Yes.
it was great. And the panelists were doing very great when being thrown like, what about urolithin A and what about creatine and what about, because everybody wants one damn thing
Yeah.
to make them live forever. Like what's the one damn thing to put my money into? And so they one of the panelists looped estradiol in with all
Mhm.
these supplements. And I
Mhm.
took the mic after him and I was like, hold on, you pull estradiol out of that group. And I'm like, if men had a drug or supplement that they could take between the ages of 50 and 60 that helped them live 2 to 3 years longer, they would all be on it. And women
Mhm.
have that drug. It's called estradiol. And we have the data and the studies to show 2 to 3 years improved years survival. That's what decreased
Yeah.
mortality means, survival, right?
Yes.
And nobody, if there was a drug that made you live 2 to 3 years longer, they would have 4 Super Bowl ads.
Yeah, and you feel better. What's wrong with
Oh, yeah, and
feeling
you feel
better?
better.
You know? Yeah.
Geez Louise, it's two bonus. Let me go back. I want to circle back to alpha and beta receptors of
Mhm.
estrogens. And some people get a little, again, in the estradiol causes cancer camp, they think it's because of the beta receptors in the breast. And so people get a little specific about that. And like, can we break that down? Again,
There
showing.
are so many receptors. There's GPER. They all do different things in different milieu. And we don't know what that is. We don't know why women get breast cancer. Let's get the research to
Can you
find
look?
out
Yeah.
that.
Can
It's not
we be
hormones.
honest about that? Like
Yeah.
everybody just wants to blame her goddamn family.
Mhm.
What's
Mhm.
your
And
family? It's your
that's
family.
rare. I mean, we know
That's actually rare.
inflammation. Yeah, rare, genetic mutations are, you know, less than 5%, and
Mhm.
we're learning more, but that doesn't mean you're going to get it. The question is, why don't all women? And then look at the latest Casapopoulos study published in December. They had the guts to give women with high risk BRCA1 or 2 mutations who would have their ovaries out because we can't find ovary cancer early, but they hadn't had their breasts chopped off. And they gave them estrogen and they lowered the risk 63% in 5.5 years.
And with is this the same paper with the Duovi arm? There
Yes,
was
yes,
no breast cancer.
no breast cancer.
So
But again,
that's a signal and should be
well,
studied more.
yes,
But
and
in
why
the
not do it with
Duovi arm,
estradiol? Yeah,
there
why
was
do it with
no,
Premarin?
right?
Yeah,
Do you think most oncologists know that estrogen doesn't cause breast cancer?
no, but they're learning.
Really?
No, they do not. The thing is, I have to say, the unbelievable 40 years of my last career is every new drug, every month, 2 or 3 new drugs. We are grateful, right? We have HER2 now. We have HER2 blockers. We have people getting treatment that's more and more specific without even chemotherapy. We're learning more and more and more about the subtypes and the triple negative and immunotherapy. They are spending all their time on what the next treatment is and how to explain it to patients. Estrogen doesn't cross their education unless we really start bringing it to attention through centers, education, and publications, and women pushing back. But sadly, what I see is that they're so overwhelmed. I've heard the doors are slammed, they're told no, the charts are thrown down, the eyes are rolled, and women have the right to ask their questions and have individual personalized discussion and make their own choice on what they want to do for their health and their risk reduction and their overall health benefits. And that's not being respected because people are so overwhelmed in their medical practice.
Yep. Yep. Yeah. And I think I need to say it because I think sometimes I go without saying. We're not blaming the doctors, we're
No
blaming the system
system.
and the
Yeah.
lack of good education. There was an education void for 2 decades. The
Hmm.
doctors who knew from the 90s don't practice anymore. You actually saw estrogen and hormone prescriptions go down after 2010. And people are
Hmm.
like, why did that happen? And it's like, because all the people who worked in the 90s who knew better retired. So it actually
Yes.
got worse.
Yes.
So
It,
a cool thing happened at Harvard
yeah.
for people who haven't heard of this, it's called WHAMS. It's the Women's Health Menopause Harvard conference, and it's already scheduled for 2027. Go get educated. It's in 65 CMEs. Oh my lord, it's
Mhm.
amazing. So two Harvard oncologists are on stage with a OB-GYN who she herself had breast cancer. It was Dr. Corinne Mann. And
Yeah.
all three said, okay, in a woman who's been adequately treated for breast cancer, she deserves a risk benefit discussion about hormones. That wouldn't have happened even 2 years ago, that comment.
No,
And the NCCN guidelines just got updated.
finally, right? I mean,
It
they're
still
skipping.
sounds scary to me. I logged on to the NCCN because they told me the NCCN guidelines got updated on this, and so I wanted to look at it before we actually met. And so I still think it's scary, but the latest NCCN update was February 2026, and it says relatively contraindicated for hormones after breast cancer. Relatively contraindicated,
Mhm.
and use caution in genetic cancer risk.
Yeah, not evidence-based. So I put that up when I speak and a big X, not evidence-based. Just like they said that different vaginal low dose, non absorbed vaginal products have a preference. You can use a ring, you can use cream, you can use a tablet, you can use a suppository. And so many women on aromatase inhibitor have such daily deprivation of estrogen to their vital vulva, urethra, clitoris, the opening to the vagina, which is urethral tissue, the vagina. They need it 4 or 5 times a week. Twice a week is
Yes,
not
twice a week is
enough.
maintenance dose for people without symptoms,
Yes.
not treatment dose.
But I've had a major professor at a university going, that is just too dangerous. I go, what's the dose of the ring? The ring is 52 micrograms a week, 7.5 per day, 90 days, 52 a week. So we have safety data. So you can use your 5 suppositories if you can get your insurance company to cover them. They dole it out like it's morphine. It's ridiculous. This is generic, cheap stuff,
Yeah.
right?
Yeah.
And even then, the poor patients are having trouble with generics. I had a patient yesterday, depending on some of these tablet packages and the generic, you try to open them, the whole thing flies apart. Some of them are so poorly made. And just like, I don't know if you've seen progesterone, several of my patients recently have had trouble with micronized progesterone. And they said there's a generic that's orange and it doesn't work the same
Yep.
as the white one.
I've
I
seen that
have the
too.
white one
And
from
they'll just
Walgreens.
switch it at the pharmacy, and then they're like, I'm awake on this stuff, and the other stuff made me sleep." So I looked into it, and I looked into it
Yes.
specifically with the patches, because women now with the patch shortages and we're swapping
Yes.
out the different brands, like, first of all, they stick differently and, all these things. Women tend to have a preferred type that's been working for them, right? But
Yes.
the generics are allowed to just be swapped out at a pharmacy. And there's actually published data on this, that generics can be within like a 20% margin of difference,
Mhm.
which is not zero
Right.
when it comes to hormone distribution. And so women are like, this one doesn't work as well. And people are like, well, take what you can get. And I'm like, you might need a higher dose on a different brand, but
Mhm.
that's real and that's published. And we've
Yes.
never talked about that on the podcast. So I'm glad we got to bring that up.
Yeah, and transdermal itself can have very variable absorption in different women. For some women, it's great. For some, it's probably the only reason to check a hormone level. The level doesn't tell us how to treat women. You ask them how their symptoms are. But if you think they're not responding and you're not getting a good level, but in perimenopause, it could be high tomorrow and zero the next day. So
Yep.
that doesn't guide us. But if you're looking at whether the patch is efficacious and being absorbed, there can be a reason to check a level then.
Yep. Let's talk about that, because I hate the black and white thinking of,
Mhm.
with a 0.075 patch and higher, you need 200 of progesterone versus you need 100 for the lower ones. And I'm like, I can give somebody a 0.375 patch and get a serum level that I can't get with a 0.075 in somebody else.
Yes.
And you're
Yes.
telling me the dose is what you're deciding progesterone on?
I
It actually makes no sense, right?
No, because small amounts of progesterone will control the uterus issue. The issue with progesterone is what helps you sleep and sleep well, what helps mood, calmness, bone health. I mean, my own, when I adjusted my hormones to get away from my doctor gave me transdermal, which is useless. It's a 21 carbon molecule. It's not absorbed. After I trained, I got smarter. And that in testosterone, my density went up 2.3% in 2 years
Your bone
because
density went up by adjusting your progesterone and your
and my
testosterone.
testosterone. I had been
Thank
on
you, Linda, for
estradiol
sharing
for
that.
years. Is that amazing?
Women get
It
told all the time that we don't have enough data, and I'm like,
oh,
that irritates me, because I'm like, not enough data doesn't mean it doesn't do
no
what
data.
we know. The bone has progesterone receptors, the
Mhm.
bone has androgen receptors.
Yes.
Testosterone helps osteoblasts function.
Yes.
Like
Yes.
not having studied women and their bones doesn't make the actual biological knowledge go away.
Yes. And the same with progesterone, muscle strength, testosterone, progesterone. So it's in so many parts of our body. But you ask a woman, does 100 milligram work for you? Does 200, 300, 400? Does it? 20% of women get on and say, I hate it. Okay. I don't know why. So if we have to have it, we try to figure out a lower dose or a vaginal dose or compound it
Mhm,
or try a different one.
mhm.
But most of them are like, oh my gosh, I've never slept so well. If I
I just
have
got
to
a
get up
woman
to
I just got a
pee,
woman
yeah.
off of her nightly Tylenol PM.
Oh, I love it.
Just I know, and
I
I was
love
talking
it.
to a sleep doctor last night again at this longevity thing, and I'm like, I pride myself in getting people off of THC gummies,
Yes.
Tylenol PM,
Yes. Yes.
trazodone. And she
Yeah.
said, she's like, that is not sleep, that is sedation. And it
Yes.
is biologically incredibly different in the brain. Like the brain
Yes.
is not getting what it needs when it's sedated. It's a very different thing than when it's sleeping.
Yes. I saw someone yesterday on trazodone. I think trazodone is one of the safer long term, but if we can taper off and do what the body was built to function on, that's what we're talking about here. We're talking about losing it because I just say we're a species like every else. We're here to procreate. We don't have to. But after we procreate, we're biologically irrelevant, but not to ourselves. If you want to maintain a healthy, long life, you have to do what kept your body optimum in our 20s and 30s: testosterone, estradiol, progesterone. Get your thyroid, make sure it's normal. Take your vitamin D, it's a hormone.
Vitamin D is a hormone.
Exercise, stress, diet, minimize toxicities. The things we know there's evidence for. But
Yep.
that will make us live better. Women are living longer, but not better.
My mother-in-law just broke her hip last week.
Oh, oh, I'm so sorry.
No hormones, no exercise.
Yeah.
Curbs will kill you, my friends.
Yep.
And I think that's the perspective the general population doesn't get about
Yeah.
the perspective that doctors, nurse practitioners, clinicians, like we put in the reps of seeing how people age.
Yes.
Right.
Yes.
And we're like, listen, you want to benefit from like, so it's two people, the people over age 90 and the people who've been married for 50 years. Whenever
Yes.
I get them into my clinic, I'm like, tell me your secret.
Yes.
And I've got
Yes.
20 years of those people telling me their secrets. And I'm like,
Yes.
that's valuable.
Yeah. Well, and I'll never forget, I was in Boston for 5 years in my fellowship training. We saw so many women in nursing homes who had had 10 kids, no calcium, no hormone replacement, bedridden. Perfectly functional women whose bodies no longer worked and they were just waiting to die. That is not how people want to live.
And I think that's the perspective that your average non-medical 50-year-old doesn't get is they're like, I
Hmm.
feel fine. Why should I
Hmm.
do this?
Yes.
And I'm like, you
Yes.
have to borrow the belief and the knowledge as somebody who's like, listen, when you want to keep traveling to see family, do you want to be the person that has to wait for the freaking wheelchair at the airline?
Hmm.
Like those people can't walk
Right.
because of
Right.
frailty. Lots of
Yeah.
people can't walk for other reasons. But like we don't have to let frailty be the reason why we can't walk.
Yeah.
Nobody
And
wants that.
I look at it as kind of like a level. After you do a full assessment, the first thing is everyone can take vaginal estradiol to heal locally. It won't heal everybody. And I see all kinds of things on the internet being sold. But the second is testosterone.
I
That is
know.
the other missing piece,
I
whether it's
know.
local or systemic, that heals the rest of it. Right.
Yep.
And then you have systemic testosterone and you've got systemic progesterone and systemic estradiol. These are these steps. And so working with women, what are their priority? What are their treatments, especially if they're on breast cancer treatment? I want them to optimize that. But, people in the middle of chemotherapy generally not worried about their sex life. They're trying to stay awake to, get through the day. Right. But when they recover, the devastation to intimacy and the amount of men who feel that they're not loved because their partner no longer desires them, finds them sexy, feels sexy themselves. It's duty sex at best. That's not what men want on the whole. They don't want to hurt their partner.
Mm-mm.
And we're not helping them unless we guide them in bio and psycho and social.
Yeah, I absolutely love it. So knowing what you know and knowing what I know about recurrence risk with systemic natural hormones after complete treatment for breast cancer, and we can get nichey if you want. We can talk like we completely neglect the ovarian cancer survivors and the uterine cancer survivors here, so we need to loop them in. But knowing what we know, two things. We know what we know about the recurrence risk with natural hormones, which is pretty much close to zero.
Yes.
And then knowing what we know about breast cancer with hormone positive breast cancer being an absolute asshole and coming back at 15 years, 18 years, how do we, with the average human brain that wants to blame something, if you're on hormones, and so my question is, how do you counsel these people? So you've decided you're
Yeah.
going on hormones because it doesn't increase the risk, and then damn it, 12 years in, we got a recurrence. We're going to blame the hormones, and now we're going to tell all of our friends and family,
Yeah.
or they're going to tell us it's your fault for taking, like, that's the problem with breast cancer is it comes back so late.
It can. And
And
I
then
say,
we wanna associate, maybe we've been on hormones 'cause we thought it was best for us, like, that's the difficulty of it. So how do you, as a physician, counsel people to be like, "Breast cancer can come back late, and that's what's so awful about it."
right, except there's no evidence that estradiol, testosterone, or progesterone does anything but potentially lower the risk in people. If it can lower breast cancer risk and BRCA1 2, and if long-term testosterone can lower risk, you will feel better and be better for the time you have. Your cancer might come back. I might get breast cancer tomorrow. I've been on hormone therapy since my 40s. I'm 71. So, I would not go off, but I know the data, right? I would say there's a whole body this cancer is happening in. We know inflammation increases risk, obesity, and probably estrone and toxic
How
estrogens
about just not
entering there.
exercising? Like, if you take
Yeah.
hormones, which make you feel better and makes your joints not hurt and lets you sleep, then you can exercise, which is phenomenal for longevity.
Yes. So these are the things that go with it. Sleep is essential to recovery too. So we can't measure all of these in a population and say, oh, everything went well. They had a lower risk. They didn't exercise. They didn't sleep well. They were stressed all the time, overweight, diabetic, had recurrence. We know all those things increase risk. So I think all we can do is be as healthy as possible. And I tell people, you might get a recurrence, but you'll live well along the way and reduce your cardiovascular risk, which is the greatest, and you will be healthier for all the other things that happen. And I really work with women with breast cancer on metabolism and getting the weight off. So many women, obesity is such an issue in our society. We are not here to shame anybody. And now we have treatments that can help women take control. And you're looking at 8 to 30% less breast cancer risk. Yesterday, less psoriatic arthritis, less cardiovascular disease,
Is that a normal
inflammation.
weight level, or is that GLP-1 data?
GLP-1 data
That's
that it's
GLP-1 data.
lowering risk. I think Eric Topol had a nice chart today on his summary. We just keep learning more things,
Yeah, he's
like,
super pro GLP-1. His book, Super
yeah.
Agers, is a great read for
It,
anybody who wants more on that.
yeah, my own partner had diabetes for 17 years. And then, you become partner with a doctor and you whip yourself into shape. He's lost 45 pounds, the last 5 on GLP-1, got off insulin, metformin, glipizide, blood sugars are good. Creatinine came down. At 79, they told him the creatinine can't get better. The creatinine got better because health is so important and low blood sugar and metabolic control.
That's amazing.
Yeah.
Are so are you doing this in your cancer center, or not you, but like people having the GLP-1 conversation with breast cancer survivors or cancer
Yes.
survivors in general, colon cancer, etc.?
Yes, they are having it. And again,
Fascinating.
the issue's been coverage, right? You have a woman with a BMI over 30 who qualifies and she gets below 30 and they cut her off.
That
So,
makes no sense.
no sense. The cost is crazy. You can do it $5 with a profit and they're still charging even 250, 500 a month. It's
Right.
scandalous. We
It's
need to bring the
scandalous.
price down.
Yep.
But for individual people, it can be remarkable in giving them metabolic control. So you can follow a keto diet, less carbs, healthy fruits and vegetables, healthy proteins, get rid of
It's a game
processed food.
changer.
It is absolutely a game changer. And again, I think we don't need it for those who are looking at size 0 and are, shrinking away. I think, there's a limit to whether we need it. I'm a big keto person. I got to my high school weight, lost the 20 pounds, really very much a low carbohydrate person because it works for us as
Mhm.
in our busy life and choices. So I think that, with its full Mediterranean or Mediterranean keto, and then do you need a GLP-1? Because we're looking at your overall health,
Yes.
hormone optimization, also thyroid. Thyroid Hashimoto's has a significant mortality risk. And my 42-year-old was born and I got Hashimoto's. And I followed my doctor's advice for years and took my Synthroid. And then they got generics, and every 90 days, the damn level would go up and down with the different generic. Then I went to brand, then I took training. And then I switched to desiccated thyroid. I've been warm for the first time in 15 years. I don't have shivering chills all the time on airplanes and 3 coats out of the shower. It's so interesting. And my life is much better. But my latest health plan wants to have you go back to Synthroid or take the Cytomel with it. It's desiccated 2-to-1 in randomized clinical trials. People prefer desiccated and the doctors don't know it. And they're all prescribing Synthroid. It's just, come on, people. It's the same cost, whether it's NP thyroid or Armor, whatever's covered. People have a different experience with it. Let them validate their experience.
Yeah. I love that. Let's loop back to the endometrial cancer people and the ovarian cancer people, because I see a lot of uterine cancers,
Yeah.
endometrial cancer. I know that
Yes.
there's rare sarcomas that get a little nichey, but
Yeah.
let's talk about your all-American endometrial cancer. I've been told I can never have hormones again. How do you
Mm.
counsel them?
Yeah. So again, there's no evidence of increased recurrence risk. Now, if you've got a stage 1 or 2, we know the vaginal low dose estradiol has been looked at in small studies. We don't have the 50,000 women years of
That
trial
we
data
have for
we have
breast
in
cancer.
breast cancer, but we know it's not absorbed. So again, raw vagina versus healing and multiple urinary tract infections and misery, we need to heal women with vaginal estradiol. Whether they go on systemic, it really depends on the recurrence risk and their priorities. So if you have a stage 3 or 4 with a 60% recurrence risk, and I go on open evidence now, I put in the information, the age, the tumor, what treatment they got, and I bring up the clinical trial data to specifically say for each woman, what is your recurrence risk? And then if, many of the estrogen, the endometrial cancers are hormone positive. And so doctors are very concerned that estrogen might stimulate it. We don't have any data that it does, but they believe it could stimulate it unopposed. So, can you give progesterone? Testosterone can treat vasomotor symptoms. So can progesterone. So, can we optimize without using estradiol? What are their other risks? What are their symptoms? What are their preferences? So, it's not a no, but in higher risk disease, it's with caution. Certainly, local treatment. Certainly, I'm not worried about testosterone. You can check the estradiol level, it rarely raises and you can get rid of a lot of symptoms. So they still should come for a consultation. Ovary cancer, all the guidelines say you can replace. And, we rip out the ovaries. We ought to wake up with a patch or a pill and treatment. And they ought to include testosterone because they've just ripped out women's ovaries early and they lost their testosterone. And they're like, well, let me know how you're doing. They're going to do badly.
I had a woman who had a hysterectomy in the hospital, woke up the next day, hot flashes, night sweats, didn't sleep, like immediate surgical menopause.
Yes.
Like
Yes.
this woman was having a period on her way into the operating room and then they removed her ovaries and uterus, right? So immediate surgical menopause. She's got all the vasomotor symptoms. They say, oh, that's you just processing your anesthesia. And then on her follow-up, she's like, I'd like a referral to Casperson.
Yeah.
And they said, well, she's going to talk to you about hormones.
Yeah.
And she's like, yeah, that's why I want to go to
Yes.
Casperson.
Yes.
She's like, yeah, I know. That's why I want to go because I didn't
Yeah.
wake up with an estrogen patch on.
Yeah.
It's interesting going back to the data of like people are saying, oh, there's no data in testosterone. It's only for libido. All this stupid shit we say. There's phenomenal surgical menopause testosterone replacement data from the
Mhm.
80s,
Mhm.
from the 90s. There's great, and then it stopped. It
Mhm.
all stopped. But it's like the gynecologist knew that when you took out ovaries in the 80s and 90s and you gave testosterone, people did better.
Right. But they
And
don't know
then we
how to use it.
forgot it.
Yeah. They
But
do not
I'm like the
know how to
old
use it.
Scrooge who's like, don't forget the original studies.
Yeah. Well,
It's
I
like,
guess one of the advantages of electronic records, which has all the torture that you can imagine, is building statements. So I've taken the time to build loads of statements in Epic, the United States electronic record in most systems. And I actually put science data in each note. I put a lot of science data and then I email the patients the papers if they want them. And what's interesting is I actually heard back from patients that the doctor said I could come see you because testosterone has a lot of benefits. They've been reading your notes. So they are reading my very detailed. I talk about vaginal, I talk about testosterone and all the benefits and the 36 randomized trials of 8,000 women that, have been summarized. And there's so much data out there, but I'm just trying to share it with doctors. So even if they're overwhelmed, I want them to say, you deserve a consult. I'm not the expert. Please go see someone. That's good enough.
I love that. I love it, and absolutely, yes. I'm still worried because there was just a very recent paper published by somebody whose agenda is anti-hormone,
Hmm.
and it said, "We don't have enough data." It called into doubt and question vaginal estrogen after breast cancer,
Oh
saying,
my
We
goodness.
don't have enough data. We don't know if we need uterine like, called out all of that, and I'm like, "You're putting back in publication what we've worked so." I mean, the boxed warning just came off in November, but, like, people don't understand we have over 50,000 breast cancer women studied with vaginal
Yeah.
estrogen. We have
Yeah.
overwhelming support for this.
Yeah.
And
And we
again,
have the
going back
gold
to the
standard.
yeah,
Gold
I go
standard systematic review, meta-analysis, including with aromatase inhibitor.
yeah. So it's like, again, I'm calling out the journal articles and the reviewers to be like, "You are allowing this to be published still."
Yes.
Say basically calling into doubt, do we actually know enough? And it's like, well, how many things do we study 50,000 people in? Like,
Yeah.
that's pretty big.
Yeah.
So
And
it's
you and I just
frustrating.
sent we just sent last week an article they haven't rejected yet. A major journal
That's a good
said
sign.
we need to teach menopausal hormone therapy now. But it also had three major errors that you and I called out, and I hope it published to enhance that. Basically, they said, well, it can cause breast cancer. No, only in synthetic progestin. Let's be very specific. It said testosterone was kind of an afterthought, and you and I really detailed the publications that benefit. And it said that vaginal low dose estradiol for women with breast cancer was theoretical. I mean, how did that pass inspection by reviewers and editors in this day and age? And I can only say reviewing is a thankless job. It takes hours to review a paper and to really respectfully comment and make suggestions to make it better or reject it because it really isn't accurate, as that menopause paper should have been rejected. It was not clinically relevant, had data without any information in it, and it made false claims.
It had relative risks above and beyond smoking and arsenic and guns, basically. Like,
Yeah.
it was so unrealistic in
Yes.
just the reading of it, but a lot of people don't know that.
Well,
They don't know that, but reviewers should. Reviewers to a
yes.
journal should.
Well, I go back in my medical training. I remember they said we should calculate the statistics in every paper ourselves, and that was absurd in 1970. It's more absurd now. But I have to say that when I went through my 80 hours of bioidentical training, it was drilled into us the quality of papers, reviewing 80 hours of the medical literature. And Neil Rozier is just a gifted instructor at WorldLink. I have to call that out. And he taught us database, right? And so we have these criteria. There's grade criteria. There's all kinds of criteria to look at a paper. And when it starts out saying we looked at a database that wasn't a prospective study, and then it had some hormones, and we don't know what hormones, how long, which ones, and this is what we found. I mean, even that paper said there's limitations, but then they said there was a finding, and that was picked up as if it was clinically relevant. That type of paper is potentially hypothesis generating, but it contradicts the Medicare study, contradicts the Menopause Society guidelines of the journal it represents. And it should not have been published, or should have been published with a commentary for clinicians, so it wouldn't have been picked up by Medscape and then false information echoed once again.
I couldn't say it better. Let's wrap up by talking about your PhD in sex therapy. What
Okay.
did you learn? What did you learn in doing that work? How do you
Yeah.
use that every day? And should I become a sex therapist?
Well, yeah, I mean, I think, first of all, in America, we don't talk about sex. We don't empower our children to understand their body, that sex is normal. It's a drive. I remember my son at one point, my younger son and his girlfriend wanted to be abstinent in their teens. I go, that's a great idea. I respect that. But if you want to be abstinent, you probably shouldn't be necking for hours, because we are made to have sex. It feels good and it's a natural drive. So if you choose not to, be aware of how your body works. And, I, at the time, um, the woman said, I thought that was just a lot of information. And later she said, why doesn't every parent tell their kids how their body works? Right. So that's number one. Number two, if you do counseling with women, there's women that don't know their body parts. I explained to a woman, what I have the little vagina with the clitoris and the urethra and the vagina opening, and they don't know their body parts.
Yep.
Right. I had
Yep.
a woman who said, she tried to get together with somebody in an older age and he had ED and she told him, it's your problem. I go, it's a partnership. It's pleasure. It's not a performance. And she knew nothing, right? So we have to start where our patients are. But I learned a lot. I mean, going through a formal PhD, I really wrote physiology and really worked on medical issues because I'm the bio part. But I trained with therapists and they were gifted. I learned so much from them. And, I have to say my guilty pleasure has been romance novel reading for many years. So there wasn't a genre I hadn't read about. So when some people were shocked by things, I'm like, oh, I read about that. I know all about that. So again, we're not here to judge anybody. You know, I am not a BDSM expert, nor will I be, but I know experts if that's your thing, right? We're not here to judge people. Consent, one of the big questions people ask is, can you do some outrageous things? And the answer is not without consent. And of course, children cannot give consent. Animals cannot give consent, right? Consent is so important. So lots of things you learn, but also all the range of physiology, medical issues. It was really great training. And my partner is a therapist, is specialized in couples. And the most couples come to therapy 7 years too late. There's already
Yeah.
so much
Is
buildup.
there data on that?
Yes, there is. Yeah, published
Okay,
data.
7 years?
Yes, 7 years. I can send it to you because it's part of his PhD.
Oh, please do, because
Yes,
I'm always
yeah,
like, as a urologist, they're always like, women wait 8 years to go see a doctor about bladder leakage.
yes.
And so I've been looking for a similar stat for sex issues.
Okay, so I will get that because they come and then oftentimes there's just so much hurt, right?
Yeah.
Women are not getting
Hurt,
their
shame,
needs met.
blame.
Men aren't getting their needs met. It's always like my favorite couple book is still His Needs, Her Needs, and a Fair Proof Marriage. It's a non-blame analysis of we have needs. If our needs are being met, our relationship probably works pretty well. If the needs, our top needs are not being met, these people have been married 40 years. It's their 20th republishing. It's great case studies. Really,
William F.
really,
Harley
yes,
Jr., His
yes,
Needs, Her Needs.
yes, in a fair proof marriage.
Building in
It's
a
an
Fair Proof
excellent read.
Marriage. Over 2
Yeah,
million copies sold.
yeah. Great
Dang,
book.
first
Highly
published in
recommend.
1986.
Yep. Great stories again about needs and understanding each other. And then people can work it out if they want to. Sometimes the hurts have been too great. They can learn to part as friends. But if you want to rebuild a relationship, you've got to have a healthy body because when you're on healthy hormones, you hug your partner, you start to feel good. So, as you know, we have the libido of I'm thinking about sex now or all the time versus, okay, you could talk me into it, right?
Yep.
I
Mhm.
start to, Emily Nagoski has a fabulous 10 minutes TED talk, sex and long term marriages,
Mhm.
about getting together, that hug, that oxytocin. Thank you for doing life with me, right? And that can lead to pleasurable sex with your partner, whatever that is. And we have to get to play. It is not performance. And especially as people get older, things work or don't work in this way or that way. And toys are essential. And have to say, I had one couple who came on. They were very unsure what this consult was about from a sex therapist, hormone doc at a cancer center. And I said, I don't want to hear anything you don't want to talk to me about. And this first, we realized that he was told he only could get a penile prosthesis. And I go, well, you're on two medicines that cause ED. How about if we stop those first, right? And then, just basic medical care. And then they came back. And then we've talked about last discussion was toys. They'd never heard of this, never been in a shop. I said, well, would this be comfortable to talk about? Right? Because vibration really helps blood flow, sensation. It can add to a relationship on your own or with a partner. But, you know, you have to ask the question or be willing to look at it. And as a sex therapist, you're trained in everything. Pelvic floor therapy, healing of the pelvic floor, right? Bladder leakage, right?
Yep.
Nobody wants to have sex and be peeing. So
Nope.
let's get healed and see a urologist, a pelvic floor specialist. So it all goes together, right? So it was
I love
exciting
it.
training.
I'm
Yeah.
so excited that you stood up at the mic to be all pedantic about hormone types because it frickin' matters. And then I have you as a friend. Like,
I'm so grateful.
thank you.
And we're going to keep writing and holding people accountable and
Yes,
teaching.
absolutely. I was thinking, I did this before the last Menopause Society meeting, is like, there needs to be some rules. These were my, like, Casperson's rules of the Menopause Society meeting. If you say hormones, you must say what type.
Mhm.
If you say hormones, you must say what route. We're not allowed to, this is how I describe it. Hormones is a big tent.
Mhm.
There are many, many things in the tent. You can't say, I can't have any of the tent.
Right.
It's simply too big.
Yeah.
So that was my, like, I think at the beginning of the Menopause Society meeting, it should be like, I solemnly swear that I will not overgeneralize and I will be specific when I use the word hormones.
Right. And the lack of data does not mean things don't work. So, yes, we're 23 years behind in clinical trials. It would give us a lot more information. But how are we going to get trials of customized testosterone dose, estradiol dose, progesterone dose, and information on women? We're going to have to do a database, electronic record, interesting consent, develop a better patient reported outcome tool that would be effective and useful. There's so much work to be done, but only together can we figure out how to get more information and improve women's long term health, get FDA to stop the Schedule 3 restrictions on testosterone for men and women, and get a female dose product approved, or have the health plans cover compounded or men's testing if you want to use male dose and adjust it for female levels.
You're a woman after my own heart.
Oh, it's so nice to meet
All
you,
of those
Colleen.
things. The only thing I would add
Yes.
is women they've been taught to be passive. They've been
Mhm.
taught to accept what the answer is. Them learning how to advocate, seek a second opinion, ask questions, know that adjustment takes time, that this is not
Yes.
one size fits all, but that your quality of life matters.
Mhm.
And there is no such thing as too old or too young. And we
Mhm.
don't too old or too young men.
Mhm.
So that just proves women are like, am I too old? Am I too young for? Am I too old for? And I'm like, stop it. You're doing it again. Like, they don't even
Mhm.
realize. I'm like, there's no too old or too young. Your driver's license age doesn't matter in this discussion.
Mhm. Yes.
It doesn't for
So
men,
true.
so it shouldn't for women. And I think that advocacy piece just adds in to the to-do list. Thus the
Such a
podcast.
bonus. Yes. As I say, we can only do better. That's why we show up to work, because we can only make it better.
I love that. Thank you so much for coming on the podcast. I hope it's not our last time. I mean, obviously, we're going to keep working together and doing cool things. Come
Thank
on
you so
again.
much
But
for having me.
thank
It was
you.
such a pleasure.
Absolutely. Till next time.
Okay. And I tell all my patients to listen because they've learned a lot.
Thank you.
Bye
Bye bye.
bye.